Before we look at echocardiography to detect ischemia, we need to appreciate the arterial blood supply to the heart. This diagram shows the axial coronary anatomy, as seen from above the heart. The coronary arteries are composed mainly of the left and right coronary arteries, both of which give off several branches as shown in the diagram. The left coronary artery arises from the aorta, within the left cusp of the aortic valve. It supplies the left side of the heart. It branches into two arteries. The left anterior descending artery supplies the interventricular septum, the anterior wall of the left ventricle and the apical cap. The circumflex artery supplies the lateral wall of the left ventricle, and in 33% of individuals, it gives rise to the posterior descending artery which supplies the posterior and inferior walls of the left ventricle. The right coronary artery originates within the right cusp of the aortic valve. The RCA primarily branches into the right marginal arteries, and in 67% of individuals, it gives rise to the posterior descending artery. The right marginal arteries perfuse the RV, while the PDA perfuses the LV posterior and inferior walls. The heart can be divided into 17 segments according to blood supply from one of the three major coronary arteries. This model, as described by the American Heart Association, is widely used to describe disease affecting the myocardial territories and wall function. In the long axis, the heart is divided into equal thirds, named the basal, mid and apical thirds. The tip of the apex forms a final separate segment. The diagram further shows division of the basal and mid third into 6 segments each. The apical third is smaller and has 4 segments. The next diagram shows the segments as seen in the apical 4-chamber, 2-chamber, and parasternal long axis views. All of these 6 echo views should be utilized when making global and regional assessment of the left ventricle. The short axis views of the LV may be difficult to differentiate on echocardiography. In general, the basal third is seen to contain the mitral annulus up till the tips of the papillary muscles. The mid-third contains the papillary muscles, while the apical third is located below the papillary muscles to the apex. When doing a Pocus cardiac scan, we can simplify the 17-segment model into 3 regions that correspond to blood supply from the LAD, left circumflex, and RCA arteries. Imaging in 3 views, the parasternal long and short axis, and the apical 4-chamber should reveal most regional wall motion abnormalities present. To summarize, an anterior RWMA corresponds to LAD occlusion, whilst a lateral RWMA is due to circumflex artery occlusion. An inferior RWMA is due to RCA occlusion. When assessing the LV, we can look at global and regional function. The LV walls should be assessed for wall excursion or motion and thickening of the walls in systole. RWMAs can be described as hypokinesia, akinesia, and dyskinesia. Here we have a normally contracting left ventricle. Note how the walls thicken in systole, and note the associated wall excursion into the LV cavity during systole as well. The P-lax view was seen earlier, and this is the apical 4-chamber view. All LV segments contract well. The parasternal short axis is seen next. The basal short axis view is identified by the presence of the annulus of the mitral valve. The inferior, lateral and anterior regions are seen, corresponding to the RCA, circumflex, and LAD territories. The mid-short axis view is recognized by papillary muscles. RWMAs are often best appreciated in the mid-parasternal short axis view, where all 3 coronary artery territories can be visualized simultaneously. We can next look at a few echo clips of abnormal global and regional left ventricular systolic function. This is the parasternal long axis view. The LV systolic function is significantly reduced. The walls are thin and hardly thickened during systole. There is only slight reduction in LV cavity size during systole. This is the same patient. The LV is seen in the apical 4-chamber view. Both the lateral and septal walls hardly contract. The walls are thin and the LV cavity appears dilated. The EF can be estimated to be no more than 15%. This is an interesting clip. Only the basal segments appear to contract in this apical 4-chamber view. The mid and apical segments are akinetic. This is an example of Takotsubo's cardiomyopathy. Another patient. Here we have the parasternal short axis view. The inferior segments of this mid-short axis view of the LV are akinetic. This corresponds to the right coronary artery territory. Over here, we have the LV seen at the level of its base. The mitral valve annulus is visible. There is akinesia of the basal anterior segments. This corresponds to the LAD artery territory. In summary, remember the coronary blood supply to the heart. Assess the heart in multiple views when determining EF and RWMAs.